So I was asked to speak. So first of all, thank you, Dr. Parikh and Dr. Chandrakanth, for getting me to speak about liquid biopsy. Very easy topic when I thought about it, and a very difficult topic when I actually started preparing about that. Because it's very fashionable to speak about liquid biopsy and very easy to speak. Let's do a liquid biopsy and get the stuff on. So I thought I'll rename my talk as current status and perspectives on liquid biopsy in oncology. And this is what I came across with the current status. That is, I think, Dr. Sahu's relationship, which was it's very complicated. It was a Karwa Chauth day before yesterday, so I can't say mine is complicated. Mine is very, very good. Then look at the future perspective of liquid biopsy, and this I felt is even more complicated. So the current status is complicated, the future status is very, very complicated. And in the next 20 minutes, I am going to simplify some of these complications for you because liquid biopsy is a very fashionable term. But what exactly are we talking about in liquid biopsy? I would say actually liquid biopsy test can be, considered equivalent to the COVID testing. Whether you're doing a rapid antigen testing or a gene expert or a RT-PCR, you need to know what exactly you are talking about. So let's begin with the first law of oncology Dr. T.P. Sahu taught me was that biopsy is the issue. And I mean, that is what, if you start a treatment only on the basis of FNAC, you are doomed, you will not even pass. And the second law of oncology actually is that tissue is always an issue. It's very easy sitting in Delhi in Rajiv Gandhi Cancer Institute and saying that, tissue should be there, tissue should not be there. But ultimately, tissue always becomes an issue, even in a high volume center like RGCI or Tata, and what to say about the second tier city. So that's not only that what I say. This is there in the journals which are basically there. So these are two things which I talk about, which basically say that in non-small cell lung cancer, 22% of people could not actually had sufficient tissue for molecular testing. Now imagine 1,20,000 people are diagnosed with lung cancer every year, and 22% of people not undergoing molecular testing, when the rate of oncogene positivity is somewhere close to around 45% in lung cancer. It's huge. Now, this is the other guidelines for colon cancer, which said that 50% of people are not recommended for colon and the KRAS, BRAF mutations according to the NCCN guidelines. I didn't speak. This was an article in 2009 JCOPO. So it is not my words. That is why tissue is always an issue. So first issue, the sample is not sufficient. The second issue is, what we, and this is a very scary issue, which I am actually going to say about it. There's a lot of intratumoral heterogeneity. We always think of cancer as an absolutely, even surface, but the cancer is not like this. There's some necrosis over here. There's some high cells. There are some high proliferative areas. There's some low proliferative areas. And there are a lot of intratumoral heterogeneity. And this is the most scary part of my presentation. They took resected specimens over there. And what they found out basically was that they did NGS in every one of them. And what they basically found out over here is that only 34% of all mutations detected by exon sequencing were present in all the 9 biopsies. So even in the resected specimen, people did try to do PDL1 staining in the tissue and in the lymph node, they had concordant results. So even if you do a biopsy, there is an intra-tumor heterogeneity which can actually be over there. And forget the intra-tumor heterogeneity, there can be inter-tumor heterogeneity also. So you do a biopsy, so we normally say that 80% concordance or a 90% concordance, but there is definitely a 5 to 10% non-concordance which can be seen between a primary in the brain or a bone or a liver metastasis. And I think there was a paper which came from the PDL1 studies in, I think in breast cancer, where they said if you take the biopsy from the liver, your PDL1 rates are much more lesser than if you take it from the breast or in the lymph node. So definitely in tissue, the tissue is always an issue. So I will just summarize the issues with tissue biopsy, which says that biopsy sometimes is infeasible, the sample can be inadequate, there can be complications like risk of doing biopsy, like bleeding, pneumothorax, etc. There can be intra and intertumor heterogeneity. There can be time to report and delay in starting treatment, especially in the COVID era. It could be approximately 2 weeks till the time we actually get to find out the report. So there is definitely issue with the tissue, and it's not a very straight road ahead. There are multiple things which will move you here and there. there are challenges ahead, and is there another way, to look at this? I mean, and definitely when there is a way, there is definitely another way to look at this, and that way basically is liquid biopsy, about which I'm going to talk. So the rationale for liquid biopsies could be clinical, it could be biological, it could be logistics. So clinical, we said, insufficient tissue, difficult to access tissue, the turnaround time, and the patient is symptomatic for the disease. For the biology, you can have intra and intertumor heterogeneity. You can be tracking resistance clones over time. You ask a patient to undergo 2 biopsies, he will see 5 doctors. You ask the patient to do biopsy at relapse, he will not even come back to you. And that's my definite feeling over here. And the logistics, the cost, the needle injury. Not everybody is blessed with an adequate IR support, and you can spare the tissue for other morphological diagnosis. So what happens with liquid biopsy? Liquid biopsy actually is a simple one-step shop where you can actually, it ticks all the boxes over here. So I hope that the audience reactions right now is that I have got you interested into the topic of liquid biopsy. And I really hope that they are looking for listening more about the liquid biopsy. So it's very easy to say liquid biopsy, I mean, but what actually does liquid biopsy analyze? So there's an entire circulome of the tumors which can be analyzed over there. Liquid biopsy essentially analyzes 3 things. One, it analyzes the CTCs. CTCs came in vogue in a very high fashion somewhere around 7 to 8 years back. But then capturing CTC was difficult. They were only prognostic. They were only prognostic. They were not predictive, and they soon went out of the vogue. You could actually look at the extracellular vesicles. You can actually look at the ctDNA. So for the practical purposes, it is ctDNA that we are interested in looking at in a patient of liquid biopsies, and most of my talk is going to be centered around the ctDNA. These are the potential clinical applications of ctDNA. They are the emerging applications. They are the current use indication. So let's start a journey of a patient of a cancer. One, you can screen the cancer. Can liquid biopsy help? Yes, it can. You either go a surgery or a radiotherapy. Can liquid biopsy help in detecting the minimal residual disease? It can help. The patient is absolutely free of disease. Can you use liquid biopsy in surveillance? Yes, you can. Do you use? Not yet. That is why I have called them as emerging complications. But what is used currently clinically is basically if you look for the mutations when the disease comes back, whether you are going to track them with responses, and whether you can find out some resistance variants which can actually be used to identify the resistance clones, which is basically currently used clinically. So this is called theory, but there is a little something missing over here, which is basically called the evidence. So, it's very nice to say, as Mungeri Lal ke Haseen Sapne comes, we will do this and we will do that. But where exactly is the evidence over here? So the clinical, I will now, so this was general liquid biopsy. Now I will go to liquid biopsy. Now I will address liquid biopsy in 3 particular cancers that we are looking at. And the first cancer is basically, obviously, if I'm talking, it has to be the lung cancer. That will be basically, can we do a biomarker detection in de novo metastatic lung cancer? The second is specifically, what is the role of liquid biopsy in EGFR mutant lung cancer? So there is where I'm going to the meat of my talk. So can we do a biomarker detection in EGFR in de novo metastatic lung cancer? That is, can we, and this will be used by NGS. So please remember, liquid biopsy is not one thing. Liquid biopsy can be COBAS, liquid biopsy can be ddPCR, liquid biopsy can be NGS. So if you have no tissue to diagnose the biomarkers, you can do a liquid biopsy, you can do an NGS over there. Specifically in EGFR mutant lung cancer, you can use liquid biopsy to detect, to monitor, and to detect T790M mutations at progression. And this uses PCR-based techniques like ddPCR COBAS. So again, liquid biopsy, 2 things. One, you want to detect all biomarkers, use NGS. You will detect EGFR, ALK, ROS, you can use anything else. But if you want to diagnose only EGFR mutant, then you have hand detection and to detect T790M. I hope, and this is not what is detected by NGS. This will be detected by ddPCR or COBAS, which are the PCR-based techniques. So again, very important, please look at what is the pathology report which actually comes over there. So I will talk about the initial biomarker detection. And this was a small study. This was a landmark study, which was basically called the Nile study. Now, Nile is a river in Africa, which basically is a very famous river. Now, this what they did was they analyzed. So they did 385 people samples. They did a tissue biopsy and they did a liquid biopsy. Okay. So what they finally basically found out was 32% of people were positive by any methodology. So they took 282 patients, they got tissue biopsy, they got liquid biopsy of the same specimen. 89 patients were positive by any methodology. Out of this, cfDNA detected 77, tissue detected 60%. 48 were detected by both of them. So what it basically said over here was that if you just look at the down slide where I have put a red circle over there, if you do only a tissue biopsy, you will detect 67% of all the biomarkers. You may miss 33%. If you do a cell-free DNA or a ctDNA, you may pick up 87% of the mutation and you will miss 13%. So that is the great thing about a liquid biopsy. There was another study which basically said a complete study, which again had taken 6,948 consecutive samples. 543 samples had tissue biopsy and liquid biopsy. And again, if you see over here, the positive predictive value, the last lines which you basically say, for EGFR mutations were 98%, for ALK was 92%, for KRAS was 100%, for BRAF was 100%, and for MET exon was 100%. So liquid biopsy, if it is positive, it is positive. If it is negative, you do a tissue biopsy, and I'll go to the guidelines for that. So we spoke about the biomarker detection in de novo metastatic lung cancer. You can use a NGS. So the same way we do a tissue biopsy NGS, you do a liquid biopsy, you do a NGS. If your test comes as positive, you take it positive. If your test comes as negative, you again do a tissue biopsy and then send the thing over there. That is the bottom line. So let's come to the EG, and this is by NGS. This is not by a specific RT-PCR or any other technique. Now let's come to EGFR mutant non-small cell lung cancer. In this, liquid biopsy can be used in three ways. One, as detection. Second is that real-time monitoring. Third is basically to detect the T790M mutations at progression. So this is the so can we detect liquid biopsies? Can we detect EGFR mutations by liquid biopsy? Yes, we can. And we have the same COBAS EGFR mutation test at RGCI. And this was basically compared against a tissue biopsy. And a busy slide, but just look at the thing which is there in the red box. You have a concordance of 87.8%, a specificity of 96.5%, a sensitivity of 75%. So, but that basically means, and you know what is the turnaround time with this liquid biopsy? If you have it in-house, 8 hours. You just take out the DNA, you will have the report next day evening. We have at RGCI, we have got it with patients who have got in ICU. You do a liquid biopsy test, you will have the report tomorrow evening. Yes, there's a cost involved to it. There's a number of samples which are involved to it, but you can get the report as early as 8 to 10 hours or maybe 24 hours also. You don't really have to wait for so much of time. So this was a fast track trial which basically showed there was a high deal of sensitivity and specificity in EGFR mutations. So what happens if you have a biopsy which is proven by tissue versus if it is a biopsy which is proven by a liquid? So if you look at the first two slides, if you have a EGFR mutation positive in plasma or in tumor, just look at it, the graphs are absolutely similar. So it does not make a difference that if you are tumor positive or if you are liquid positive. If you are positive by liquid biopsy, you are positive as good as if you are positive by the tissue biopsy. So definitely EGFR mutation can be easily assessed if we do a liquid biopsy to start with. So this was an article which was an editorial article which came in the Annals of Oncology in 2018. And again, this was based on the IFM trial, 652 patients. Again, the specificity was 99.8%. So the bottom line in liquid biopsy is if you have the biopsy, if you have a mutation which is positive, it is positive. If it is negative, go ahead and do a tissue biopsy and then go ahead and then do the testing once again. So this I spoke about. So again, just to remind, we spoke about two issues. First, if you want to detect all the biomarkers, please do an NGS. If you now various NGS things are available, you have Guardant, you have Foundation Medicine, you have the Thermo Fisher one, and everything else is available. But if you want to detect only EGFR, you use either a ddPCR or a COBAS. A COBAS has got a higher specificity, low sensitivity. ddPCR is very, very sensitive actually. Now, let's say you have given gefitinib or erlotinib or decomitinib to some person, and the patient will progress after 12 to 14 months. Then you can detect a T790M mutation. And again, this can be detected by either liquid or plasma. Doesn't make a difference if you have liquid or plasma. You will do equally well with osimertinib. And so if you have a T790M positive, either in liquid or a tissue, you can give osimertinib and the patient will do absolutely fantastic. So what are the guidelines say? And these are the guidelines which basically says, and again, this is a gist of the story. Please look over here. Now, this is a patient with advanced treatment naive non-small cell lung cancer. That is the patient has just come in. So you find out whether the tissue biopsy is available. If it's not available, please look over here. You please do a ctDNA analysis, do a NGS. If the therapeutic target is positive, you can treat with a standard of care based on the presence of oncogene driver. If it is negative, do a tissue biopsy. So the IACLC guidelines basically say at de novo, try to get a tissue. You are able to get it, fair enough. If you are not able to get it, liquid is absolutely okay. But what happens at relapse? In fact, at relapse, they say, don't even look for a tissue. Start with a liquid biopsy. If you have a targetable resistant mutation positive, go ahead with that. If you don't have a tissue, if you don't get anything in liquid biopsy, then you go ahead and do a tissue rebiopsy and go ahead from there. Tumor mutation burden. So, how can you finish a talk on lung cancer without immunotherapy? A tumor mutation burden was coming up in a big way. This was assessed in a blood also, which is basically called the BTMB. And again, they found out that BTMB was equal to the TTMB. But again, there are a lot of controversies regarding TMB. I'm not going to get into it. What is the optimal cutoff value? 12, 14, 16. And I think a lot of search needs to be done for TMB. But yes, liquid biopsy can actually detect the tumor mutation burden also with equal risk. So that finishes my lung cancer liquid biopsy. Now I will go to clinical applications of ctDNA and MCRC. So again, anything in liquid biopsy, if they are DM resident people or DNB people are listening, just say three. You can have mutations as biomarkers, you can do a dynamic monitoring, and you can track the resistance. So that's the by and large three headings in which you should write your answers upon. So again, this is a slide which I showed you before. Nearly half of the MCRC patients do not get the guidelines which are recommended by MMR or something. Again, as we can detect the primary EGFR mutation by COBAS, we can detect the KRAS and the BRAF mutation also in plasma in people who do not have enough tissue available, and the sensitivity and specificity is also very, very high. Again, depends on whether you have a beaming or a ddPCR or a Guardant 360. But that's not what is important. What is fantastic about colon cancer and liquid biopsy is that if you give, you have a KRAS wild type person, you give them cetuximab, and then the patient progresses. Now you do a liquid biopsy, and what it has shown is that you can have a RAS mutation, you can have an extracellular domain mutation, you can have a HER2 amplification, you can have a c-MET amplification. So this will help us in either rechallenging versus you want to add an HER2 therapy versus you want to go ahead with an anti-angiogenic therapy. So this is a huge potential role which I think has a liquid biopsy as a research subject in colon cancer. Now, that finishes my colon cancer. Breast cancer, we know the SOLAR-1 trial, which basically says alpelisib plus Pastolex versus the other one. And this trial had used PIK3CA mutation either by tissue or by liquid biopsy. And again, if we say, if you have a PIK3CA mutation either in the tissue or in the plasma, alpelisib is going to work absolutely similar. So this is the third indication of liquid biopsy, which is clinically approved. And these are three indications which I've shown you. one for primary EGFR mutation detection, second in primary detection of KRAS, NRAF in colon cancer, and the PI3K mutations in lung cancer, in the breast cancer. So last 5 minutes, and I'm going to tell you something about the future and something which is very, very dear to me. I think that is where the future of liquid biopsy is going to come to be. You can actually monitor you can have a dynamic monitoring by liquid biopsy. And I'm not sure whether Dr. Purvish Parikh remembers it or not. In 2 years prior to this, an icon we did ask for a grant, academic grant, which we got finally for dynamic tracking of EGFR mutations. The results are going to be out hopefully this ASCO. And we have actually found out that patients who lose their mutations at 3 months or 4 months interval are the people who are doing much more better. T790M, we could not get the results because of the COVID pandemic. People are not coming. But if you have a EGFR mutation at baseline, people who lose the EGFR mutation at 4 months of time are the ones who do much more better. So that is one thing. Again, to monitor MRD. So let's say you have a EGFR mutant early stage non-small cell lung cancer, for which you want to decide osimertinib or not. In that patient, if you have done a surgery and you have given you chemotherapy, you look at the MRD. If the MRD is not there, please don't give osimertinib. That's a hypothesis. If the MRD is there, you can probably give osimertinib, but that is again something which liquid biopsy can say. Similarly, in immunotherapy, again for durvalumab, also they have said that people who do not have any measurable ctDNA at 6 months of durvalumab are the ones who are going to do much more better with this. So last 4 slides. I was always talking about, we all spoke about the foreign data, and most of the guys would have been asleep by now. And just fine, this all will happen in the West, and in 10 years time we will, think about doing this over here. And Modi ji told us to be Atmanirbhar Bharat. One way of saying that also is apna apna dekh lo in the COVID scenario, but that's not what I made it out across over there. I thought let's look at our own data. So this is our own data which we have submitted for publication actually. We had 117 patients of lung cancer who underwent simultaneously ddPCR and COBAS. So I'm going to present you data of 76 patients of primary EGFR detection by COBAS. And this is our data, slightly busy slide, but just look at this. Our data of primary liquid biopsy is the sensitivity and specificity to the tune of 94.5 and 97.4, because we have a well-oiled machinery of taking out the DNA, analyzing the specimen, and if you look at the ROC curve, I mean the Z statistic score is 25, significance is very, very high, and the values are very, very significant. We have submitted for publication over there. Both in DEL 19 and L858R, the results are actually fantastic over there. This is one more article which we have published in AMP, our data of T790M population. And again, our data of T790M does not say 60% people will basically get T790M. Our data actually says 50% of people do get T790M mutation by ddPCR. But if they get the T790M, if you get by either tissue or liquid, the results are by and large equally similar. So this is one thing which I have taken from Tata Memorial, Dr. Kumar, Prabhash, Vanita, madam, that we should have our own Indian data. Enough of talking about the Western data. We should implement that thing into the Indian context and take it from there. So my conclusions: liquid biopsy is fast emerging and probably emerged as a valuable tool in the management of cancer such as non-small cell lung cancer, colon, breast, CA. It is a high concordance rate with tissue biopsy, is far more easier, convenient. Established role in EGFR detection, primary or secondary. High concordance rate with NGS. Emerging role in immunotherapy. So will liquid biopsy replace tissue biopsy? I don't think so. I think they both will be complementary to each other. If the cost can be limited, probably we can, do tissue and liquid both for everyone. And that is also a project that we are doing right now at our center. And hopefully that will tell us the answer. And I would like to say, summarize, like liquid biopsy is like Donald Trump. You can love him or hate him. You cannot ignore him. And I normally said, next 4 years are going to belong to liquid biopsy. I don't know whether the presidential elections are the results of that, but time only will tell. So with this, thank you, and hand it back to the organizers. Thank you.
That's a very informative talk, sir, and we all enjoyed the last half an hour. We gained a lot of take-home messages. So I think we can share the post-module questionnaire. The link can be shared in the chat box. In the meantime, sir, for discussion's sake, we can have few questions and we can discuss. So we had a patient who was a 50-year-old lady who had the lung mass, brain mets, and then wanted a biopsy from the lung and turned out to be COVID positive. And now he is stuck with a COVID positive report. And of course, I have counsel for starting on Jeftinib for whatever benefits. So am I legally and scientifically safe if I have a EGFR positive and I can go ahead and treat this patient?
So no, Chandrakanth, can I have your question once again? If you have a
So we have a lady with a lung mass and multiple brain mets,
okay,
not much symptomatic for brain mets. So she turned out to be COVID positive during hospital stay. So biopsy could not be done.
okay.
So now the COVID to turn
So
negative, it will take at least a month. I don't know how long it takes. So can I start? I will send a peripheral blood for EGFR or whatever gene panel. So I don't have a HPR. So no HPR, only mutation present. Can we give? So what
So
is your
I
take?
don't think I think you should always have a HPR. I will always vouch for a HPR. I also said you cannot replace a tissue biopsy with the liquid biopsy. But you just can get an FNAC from one of the sites, prove malignancy, and then go ahead. Medical legally will be much more safer. Dr. Parikh, I think, can tell you much more about that. But I will any day want to have a histopathological proof for that.
Okay,
Dr. Parikh, sir, can you comment on that?
I think it's not there.
No, sir is there. I can see him. Dr.
I'm
Parikh,
un
sir.
yeah, yeah, I'm unmuted now.
Okay.
Sorry,
Yes.
I took a little while to get unmuted. So you have a very important question. If it is a new patient who has never been diagnosed with cancer earlier, I would agree with Ullas that we must have a histopathological diagnosis. If the patient was earlier diagnosed with cancer, now has progressive disease and it is consistent with the clinical picture, then we need not have the repeat tissue biopsy.
So in these special situations, sir, where none of them are willing to do a biopsy with a COVID positive report, and it may take 1 month for the patient to turn COVID negative. So am I legally protected if I start them on a TKI with whatever evidence if I have a EGFR positive report?
So I would say that you have two options. One is to cover your ass, the other is to do what is right for the patient. I hope that
Okay.
answers your question.
I have a
Okay.
feeling, sir. I think our radiologists are you take into confidence your radiologists. Tell them nothing will happen with COVID. Go do. You do an FNAC. I mean, we are doing FNACs left and biopsies left, right, and center now. Yeah, so ho gaya COVID. Delhi is the COVID capital of India now.
Okay.
Okay. Chandrakant, I think you have one more question which said liquid biopsy reliable for recognizing all type of mutations and PDL1. No, PDL1 no. There is no relation of PDL1 with NGS. Again, we are trying to do a testing on that, but it is not. But other type of mutations, yes, if you get it from there, yes.
So you agree with those Garden 360 Foundation one liquid biopsy are
So,
reliable?
see, the typical thing over there in liquid biopsy is if it is positive, it is positive. You also have to talk to them, your molecular pathologist, what is the frequency, what is the VAF, what is the MAF? Is it not a something kind of just going on? If they say it's a pathogenic mutation, then yes, you can start. And that's why I showed you ISCLC's statement over there.
Okay. So the next question is, uh,
Does that make any difference in the prognosis? I didn't get this question.
I think we couldn't get the context in which she was asking. Yeah.
So I would say that if the treatment is going to change based on the report, then obviously prognosis will also change, right?
Yeah. So we had a test from one of the diagnostics where they found out the number of CTCs in a patient on adjuvant breast cancer. So the patient did the test and had some viable cells. So what do we do if the patient comes with this report because he was speaking on the future directions? So what if I'm countered with a
I think
report of
CTCs are there in breast cancer after 2 to 3 months, and they are only prognostic whether the disease will come back or not. I don't, to the best of my knowledge, I'm not yet sure that whether you have a CTCs which are there and then they say you stop chemotherapy, things are going to be like this. I'm not really sure of that. See, that is what, I think we need to talk to our pathologists. We need to look at them. कि भैया क्यों कराया था? I mean, that is what I really want to know. Okay, why was this test actually done? Just because it's India and you can get a test done, why unnecessarily you got it done? I won't act. And Dr. Sahu has also said he won't act.
Right.
So,
So,
as Dr.
and
if Dr. Sahu has said, then I won't act.
CTCs are also, fading away as opposed to liquid biopsy and cell-free DNA and cell-free tumor DNA.